Now to introduce our opening keynote, Leah Binder, President and CEO of Leapfrog. I know you know who she is. I don't know if you know this. I want to also recognize that Leah was once again just named to Modern Healthcare's list of top 100 most influential people in healthcare. They said you're not number one yet. I'm like, we got to make some calls. Come on up here, Leah. Congratulations.
Thank you. Thank you all. Well, I'm very pleased to introduce a good friend of Leapfrog, and most importantly, a shining star in the movement around patient safety. Sadly, Joe Kiani was not able to be here in person today due to some last-minute problems, but we do have the benefit of technology, and we're going to use it. So he will be able to speak with us anyway, which I love. Joe founded the Patient Safety Movement Foundation, which is a nonprofit that works toward eliminating deaths from preventable medical errors around the world. This year, Joe led us in a very significant milestone, which we were very excited about. And that was that he was co-chair of the President's Council of Advisors on Science and Technology. This is one of those DC acronyms, PCAST, which he, by being a member of PCAST, was able to get a patient safety report published, formed a work group that he co-chaired, and developed a PCAST-approved set of recommendations for the president, which are sitting on the president's desk. And we will hopefully soon see some action as a result. But it is not often, in fact, probably never, that the White House has been formally recommended a set of principles on patient safety. So very exciting, and really the leadership of Joe Kiani that made that possible. So we were extremely excited to see this. We think this is truly be a breakthrough to have this level of attention at the national level to the issue of patient safety. Joe's relentless efforts to make patient safety a true priority have really paid off, both from the Patient Safety Movement Foundation, his work in the general movement, of which Leapfrog is a part, and certainly now with this latest PCAST effort. I want to thank him personally for his leadership, his commitment to this incredibly important work. Now, he has a day job also, for which he gets, he has a salary and a day job. He does this on the side. But his day job is that he leads Masimo, a very large company, a global medical technology company, and that produces a wide array of industry-leading monitoring technologies. So please join me in welcoming our opening keynote, Joe Kiani. Welcome, Joe.
Thank you so much. I will begin by thanking you all for the great work you're doing. Leah, you, the staff, the entire board have for 2 decades nearly pushed patient safety and have done an amazing job getting hospitals to pay attention to patient safety. Medical errors are probably killing nearly 200,000 people in our country still, 3 million people worldwide, and your work has reduced that. We have not yet succeeded to get to zero, but we've made a lot of progress, and I think today I want to talk about some of those, but also I want to just tell you how upset I am that I can't be with you. My day job has needed me more than ever. We have, unfortunately, an activist who's come in and threatens the very survival of our vision, plans, and future. So I apologize I couldn't be with you, but I have to be here to take care of some things that are right now urgent. I'm really glad my colleague, Dr. Mike Ramsey, is there with you. I'm happy He's representing me and our work at Patient Safety Movement Foundation, and he'll be with my colleagues at Children's Hospital of Orange County, where they so deservedly are getting an award today. And I wish I could be there to shake their hands and thank them. You will hear it later, but their work by implementing evidence-based practices, by doing the just culture, has saved numerous lives. They went almost for 6 years without a single preventable death, which is really an amazing accomplishment. If every hospital had done that, we would be very close to zero right now. I want to also tell you that it's been a hard road. We began a little over 10 years ago. Out of sense of responsibility, I have this philosophy of micro fixing, trying to fix the things I can. And unfortunately, there's a lot of big problems in the world that many of us can't fix. I can't fix, but there are things we can individually fix. And I felt this was something that I could try to help, I could try to fix. And that sense of responsibility led me to begin the Patient Safety Movement Foundation and hold our first summit. We couldn't have done it without the incredible commitments of many, many people early on, from people like Robin Betts and people like Charlie Michelli and Mike Ramsey and so forth, to, of course, President Clinton, who came to every one of our summits and helped us get this message out there in a much bigger way than we could have ever done without him. And the work we've all done together has resulted in incredible attention to patient safety worldwide. I sometimes liken it to happy feet, that we've let the world, ministers of health around the world, now pay attention to patient safety. I think the 5th or the 6th ministerial summit on patient safety will be in Chile this year, where ministers of health from around the world come to talk about what they can do to improve patient safety. The World Health Organization has now made a Patient Safety Day, September is, I think, 17th, and has got a goal for 2030. And as Leo mentioned, even President's Council Advisors on Science Technology recently issued a report to President Biden, which we had a chance to meet with and go over what we recommended, and it went very well. In fact, we just got an update from the White House. They truly are in the thick of it, trying to implement it, which was so good to see. And I want to talk a little bit about that, but I got to tell you, I'm a beneficiary of the things we preached. A lot of times Dr. Ramsey says we're all going to be patients one day, and it couldn't be more true. September 28th, my son found me unresponsive in my office about 10 o'clock at night, called 911, and there's a long story. There's some bad examples of what could go wrong in patient care, but eventually I got to University of California, Irvine. And UCI was the first academic institution to implement all of the evidence-based practices that we had created over the years. And a year earlier, I had actually used them to save President Clinton's life when he was rushed there during his birthday with sepsis. Unfortunately, they did a phenomenal job. But I was also the beneficiary of their incredible care. And I got to tell you, what I witnessed was remarkable. Team-based approach in my care, protocol, everything's protocolized, from putting central line in me to giving me my medication, going for my walks. And then the respect that everyone showed each other, the nurses, the doctors, had created this incredible culture. And really the loving care that I got, I felt like it was almost in a spider's web. Every time I moved, the nurses would come and respond to me, wondering what do I need. And because of that, I survived. I survived it. I had gotten, unfortunately, aneurysm, sub, uh, right in the center of my head. My veins had popped. They had coiled me. Uh, thank God they didn't open my head, although I know that's the old way of doing it and sometimes the necessary way of doing it. But they actually were able to put coils in my head. And I spent 3 weeks in the neuro ICU. And that was interesting. Knowing how about 1 out of 5 people who get opioids get addicted to it, I initially refused opioids. And for those who know what happens when you get a lot of blood in your head, it's a very, very painful journey. And after 2, 3 days, my head was in such pain. All I could imagine is someone just chopping my head off just so I could get rid of the pain. I soon said, fine, give me whatever you have. But by then it was a little too late. The opioids that were given to me intravenously weren't working anymore. I was in this terrible cycle of pain. But they did something experimental on me where they actually gave me a block. They put these cannulas up through my nose and right into where the pain, I guess, had started, and put the opioids directly in there. And within 20 minutes, the pain started subsiding, and the normal opioids began working. And at that point, I wanted a T-shirt that said "Opioids rule," but it didn't stop there. I think it took me less than 2, 3 days to become resistant to the opioids. They were giving me as much as they were supposed to give every 6 hours, and I needed it more. I needed it every 5, every 4. And apparently I became very, very mean and unruly. And fortunately, I don't remember any of that. But my team brought a device called Bridge that we licensed that puts pressure pulses on your vagus, occipital, and a couple other nerves. And God, within 20, 30 minutes, I was human again. And I was able to go over a few days from the full dosage to 2/3 to 1/3 to 0. But I started feeling a lot of pain in my tailbone. They had to keep me on this angle to drain the blood from my head, but also not get hopefully venous thromboembolism, which, by the way, I did get. I used to want to go for walks every day, and after about a week and a half, I couldn't even put my foot down. It's so painful. They thought maybe I'd kicked my leg to the bottom of the bed. So they did x-rays, nothing broken. They should have done an ultrasound. I've learned we have to make sure that's part of the evidence-based practices when someone complains about pain. But actually, the fact that they didn't discover it right away probably helped me, because at that point they couldn't have given me blood thinners. I would have had to put filters in me. And fortunately, they did discover it a week later, and that's what kept me there for a little longer. But then by then, my brain had stabilized, and I was able to get blood thinners, Eliquis. I was on that for a few months. But this whole journey, I mean, half the time people die. The other half, they have deficits. And of course, we all know when you're at the hospital a little too long, things can go wrong with you. But I survived it. I'm grateful to UC Irvine for the way they gave me my care, protocolized. And every hospital I wish had their evidence-based practices in place. You know, we learned about these evidence-based practices working with the work that Dr. Peter Pronovost had done with CLABSI that was implemented in Michigan, a checklist of simple steps that everyone could remember to follow to minimize CLABSI. So that's what led us to, at Patient Safety Movement Foundation, every year identify a few of the problems that were killing people and had evidence-based practices to avoid them. And then with a group of experts and patient advocates, we were able to create these evidence-based practices for everyone to use. And by the way, they're free on our website, and we encourage everyone to use them. But I think, as you all know, this is a journey where the people that do the work are usually part of the choir. And really the only way I believe we'll be able to get every hospital to provide the kind of care I received that saved my life is to mandate it. I think it's hard to say those words. I'm not one that wants those types of mandates, but unfortunately, I think it's clear now after the first report to Err is Human, how this is not, the evidence-based practices are not ubiquitous at every hospital. At best, I know about 100 hospitals that have implemented all of them. The rest, some none. So that leads me to PCAST. With PCAST, I was fortunate to be invited to be part of that group, an amazing group of scientists and engineers. And we are tasked to recommend to the president of what can be done on science and technology. And thanks to President Biden wanting us to attack patient safety, the group agreed to go after patient safety. Eric Horvitz, who's the chief science officer of Microsoft, and I co-led the group. We co-chaired it. We had an amazing PCAST group on our own, but we also invited some advisors to the group, like Dr. Peter Pronovost, Dr. Don Berwick. We had patient advocate Sue Sheridan. We had a wonderful representative of the nursing, and now I'm drawing a blank, a good friend of mine. But we had the National Patient Safety Transportation Chair, ex-chair on this group. And it took us 2 years. We met with every agency. We met with many hospitals, many experts, and we finally came up with a report that we presented to the president. And the whole idea of this report is to give the president what he can do without legislation. So it's all about the strength and power of the presidency and what can be done without anyone else helping him. Fortunately, he's got about 2 million employees, HHS, CMS, so there is a lot he can do. And given that in the US, half the hospitals payments are made by the government through Medicare, if not more through some of the local state agencies, there is a lot of leverage that can be brought in to improve patient safety. And we all know quality not just saves lives, but quality saves money. Quality brings in revenue. If you ask Toyota why they approach this quality that they are famous for, it wasn't just to have better customer satisfaction, it was to reduce their costs. So every one of the evidence-based practices I'm aware of, if you implement them, if not within a few months, within a year, it'll pay for itself. So let me tell you about what our recommendation to the president is. Number one, make the HHS secretary responsible for patient safety. Number two, hire a White House coordinator like he has for the Cancer Moonshot to watch over the agency's work and coordinate them so that hopefully whatever the president wants to get done will get done. Third, create a national patient safety team to include not only experts in patient safety, but the stakeholders that are most affected by it, and have them focus not just on patient safety, but the workforce safety. We can't expect our employees or workforce, doctors, nurses, to care about patients if we don't care about them. So both have to go hand in hand. The next thing was to ask the federal agencies like AHRQ and CDC to come up with a list of what is still killing people from medical errors. Years ago with the Obamacare, the focus was on what's costing Medicare the most. But no, this time the focus will be what is harming people the most, what is killing people the most. And those problems, if they have an evidence-based practice that could be implemented to mitigate them, then they would become the first set of 10 priorities. So things like medication errors, hopefully CLABSI, failure to rescue. We expect them to identify those and then come up with the evidence-based practices, and then expect every hospital to implement them. And if necessary, align the incentives so that they get paid for everything, the primary care as well as the secondary care, even if there's harm, to deal with the harm if evidence-based practices were in place. If they weren't in place and someone gets harmed, then there should be no payment, not just for the secondary care, but not even the primary care. One of the lessons I got from my years of serving at the board of CHOC and chairing the quality committee is how well aligned incentives work. CHOC Group had done a tremendous job in improving patient safety years before I got there. But they were looking at the initiatives that Medicare was looking at. The goal was to be better than the others. The goal was not zero. And I asked the question, why can't that be the goal? And to their credit, they agreed and they made zero their goal. But they went one step further. They tied the faculty's bonuses to zero. Now, after they did that, I saw something incredible happen at the next board meeting. They had actually gone through the Patient Safety Movement Foundation, evidence-based practices, the Joint Commission, I think they called theirs STS, and they had marked green for the things they were doing in each of those categories, yellow or red for what they weren't doing, with a mitigation plan to get them to green. That's when they went, I think, and I kind of started saying that's what they went from hoping for zero to planning for zero. So, and the first year they did not reach zero. But again, to their credit, they didn't come and say, hey, we didn't get our bonuses. This is not an attainable goal. We should back off of this goal. They did not do that. In fact, they went further. They doubled down. They increased the bonus amount for zero. And I'm happy to share with you that almost for 6 years, they had no more preventable deaths. And while there has unfortunately been a recent event, it wasn't to do with the evidence-based practices areas that we were working on. It was something completely unrelated, but still should have been avoided. To their credit, they counted it. So back to the PCAST recommendation. So aligning incentives is important. It is fundamental to getting every hospital to implement all of the evidence-based practices. And please understand, we're not looking for a result. We're hoping for the result, but we're looking for action. We're looking for people to do what they can do to avoid patient harm, which is to implement these evidence-based practices. The other thing is we think transparency is important. We believe we've recommended to the president that every hospital at least annually reports on their website all the harm, all the preventable harms, and also reported to HHS. And we believe that transparency will do many things, including hopefully getting hospitals to not want to have a lot of them. Hopefully it's a good area to compete on quality. But also we can learn from it. To this date, we don't know. We don't know the exact number of harm. We don't know exact number of harm by category. I mean, imagine what we could learn, what we could focus on once we have this information. So transparency, aligned incentives, evidence-based practice implementation, the National Patient Safety Team. But then we also want to have new technologies help. AI is great at predicting problems. It's pattern recognition. And this is a great area for AI to thrive, because while clinicians can focus on the screen or on the slide or the images or the blood information they just got, but then they go to the next patient, AI can be there 24/7, looking at all of that data, looking at historical trends, maybe even back to how people are when they're home, when they're not sick, and use all that information to bring in precision monitoring and hopefully precision care, and hopefully help 1 Sigma clinicians be 6 Sigma clinicians in identifying problems before they're too late. So, but to get AI to help, we've got to stop walling the data. Companies like mine, they have to share their data. So we're recommending ONC and others to incentivize companies to share their data that their products are purchased for, to invest in science like AI, to do research, to bring some funding in, to do more research on patient safety. So while there are several other important things, those are the main items we brought to the president. We're hoping that his administration will implement these. We're seeing that they're already working on it. And I hope you guys can still see me. Okay, I'm back. So I just want to say maybe this is actually a good time for me to stop and see if there are any questions. I'm happy to take them. But I just want to give you one more piece of data that I think was important in my care at UC Irvine. I was able to go home earlier and get virtual care. And as you know, the longer you're in a hospital, the chances are the more you increase the chance of something going wrong. So there's a future coming, thanks to COVID accelerating this telehealth, telemonitoring, where we can hopefully give everyone the care I have through not just evidence-based practices implemented in hospitals, treating opioid addiction, but also sending people home earlier. Thank you.
Hi, my name is Stephanie Taylor. I'm a physician, and then I became an architect as well because I was so concerned about the building and patient safety. And I really appreciate your story. So I now work around monitoring the air and creating data around the impact of the air. And my question is, in my trying to roll out what we're doing, we have come across a problem with people being afraid of collecting certain data points because that could result in legal actions. And so I think that's been a huge blockade in collecting data that's related to human health. But I also wanted to take this moment, and Leah, I hope this is okay, to tell you, in my current startup where we monitor the air and we have a health index, our very first installation was in the Leapfrog headquarters. And so I really want to thank you, Leah. Their air quality is absolutely amazing for the most part and supports human health. But how do you get around the fear of litigious activity when you collect data?
Well, thank you. Thank you for that question. First of all, there's some incredible people in the room with you, like Dave Mayer, who did a lot of good work in Chicago and then later at MedStar, who pushed this idea of candor. And the whole idea of candor, I think, goes back to the Michigan Boothman. Part of it is you got to do the right thing. And if you do the right thing, good things will come. And the right thing is, if you believe you've harmed someone, within 30 minutes, you should apologize to the family. Because that's a huge step in healing for not just the families, but for the clinicians involved. But by facing up to the problem, not trying to hide it, worried about litigation, the organization can learn from it, can do root cause analysis, and then can hopefully implement changes so that that won't happen again. The thing they did that they learned is if they paid their lawyers a fixed fee, whether the case was settled immediately or went on for years, that the cases would settle and that there was a just amount of money to give each time. And it ended up costing the organization a lot less. In fact, if my memory is right, MedStar, through this program, I think saved $70 million and reduced medical errors by, I think, over 50%. So, you know, I always believe doing the right thing is what we're set out here to do. And in this example, it shows that it also helps the organization save money, save lives. So I would maybe follow the candor program and not worry about it, apologize, incentivize your lawyers to do the right thing quickly.
I actually have a question for you, Joe. The PCAST report was such a huge moment for patient safety. I'm just wondering what is next, and how can we in this room actually be a part of it? Like, how does someone like me become a part of something like that?
Well, one thing that I would love if everyone was able to look at the report, if everyone would urge their local government bodies, legislators, that they want to see something like this adopted nationally, even as a law, and really push HHS to make these changes. Like I said, the good news is last Friday, we had a PCAST meeting, and Danielle Carnival, who works for the president and heads up the Cancer Moonshot, gave us an update. Fortunately, they are working on it. But they do need you guys all to know about it, to talk about it through social media, through letters, to give them the backing they need to push it all the way through.
I'm a general pediatrician, and I attended the Safety Summit this last year. I was really inspired by that, and I've been doing a lot of thinking, read through the PCAST report, which you also spoke about in our board quality meeting, so I got a chance to read through that. And I really think that the transparency piece of the different bullet points is very, very important, and have been noodling through, what you've talked about with regards to a national database of safety reporting across the country. And I wonder, you're talking about, writing to senators and getting the government involved in things like that. Is there any? Has the needle moved on that, in your opinion? Do you feel like we're making any progress towards states and health systems adopting and having the courage to do something like that in a single repository that patients and other healthcare consumers can kind of look at to judge what a health system safety record truly is?
Thank you, Charlie, and thank you for what you guys have done and the amazing culture you have at CHOC that has allowed this transformation to occur. It takes courage. It takes patient-centered approach. So thank you. Yeah, first of all, I want to be very, very clear. We are in a moment where we have tremendous momentum. We have not achieved zero, but we've made a lot of progress. The work you all are doing, both at Leapfrog and individually in your hospitals to push things forward, is making a big difference. Is there legislation statewide? Unfortunately, maybe Maryland might be the only one who made some progress there, but no, not ones that I can really talk about. We think the solution has to come from the administration. We believe the president, who is probably the nation's biggest patient advocate, is the one who can do it. Unfortunately, this new war in the Middle East has disrupted a lot of the momentum that we were expecting. But fortunately, the people that work for the president are working on it. So, but I don't think we should give up. I think this patient safety report by PCAST, I think, is giving a lot of local legislators, national legislators, some thought, some support. So this is the time. This is a time that if you know anyone that you think can help, you should. And I take it back to your own hospitals. If everyone that works at a hospital took it on themselves, that they are the ones that have to be the champion of implementing evidence-based practices, of transparency, and all these good things we know that work, we can get there. We can get there. So while I think this is a time to push our governments to do something, it's also a time to really just do it at every institution that you are at.
I'm wondering if the PCAST report or just the work group in general talked about patient safety in other settings, such as ambulatory surgery centers, or just in general, all the many settings of healthcare that could benefit from improvements in safety.
We did. Our focus remained in hospitals and ambulatory surgery centers, but we did, and we do understand the problems are outside of those settings as well, from a dentist office to oral surgeons to nursing homes. So we get it, but given the levers that the president could pull, a lot of it being because of Medicare payment, we felt if we stayed in the confines of where Medicare was paying for patient care, we could hopefully get things done. And there should be a broader set of recommendations if this was going to legislators, but we focused it on what President Biden could do.
Hi, Joe. It's Mike Ramsey. Great talk. Thank you. And thank you for everything you've done for patient safety. Really appreciate it. And Leah, what you've done too with Leapfrog, one of the things that Joe's been very clear about, was transparency of data. And Leapfrog really got into that first by grading hospitals. We're all competitive. I was on the board of a big hospital in Dallas, Texas, and if our Leapfrog grading wasn't as good as the other hospitals in Dallas, or better, it made the hospital administrators have to do something. And so I think that's really important. If you look at some of the CDC reports that are just coming out now, we're starting to get more data, and this is where I hope AI will really help us with good data. But on death certificates now, if there's a maternal mortality, it has to be written on the death certificate. So now we're starting to get real data. If you look at Norway, 2 mothers in every 100,000 births die. In Netherlands, it's 4 mothers for every 100,000 births. UK, 10. If you look at the United States, it's 33. What is going on? That has to be publicized. We have to know that data, and we can do something about it. Let's go to Norway and see what they're doing. Get the evidence-based best practice and put it in place. So anyway, Joe, thank you so much. That was really inspiring. Thank you.
Thank you so much. Mike Ramsey is the CEO of Patient Safety Movement Foundation. And hopefully, Mike, you'll be there for the Children's Hospital of Orange County award on my behalf. I really wish I could have been with you guys. I really wanted to spend the whole day learning from you and being with you. I'm so sorry I couldn't be, but thank you so much for having me.
Well, Joe, we want to thank you for being with us, and thank you for all your superb work that you do for all of us. Ladies and gentlemen, Joe Kiani.